Welcome back to School. The last session we have discussed about management of heart failure with evidence of fluid overload to manage with the diuretics and the side effects of diuretics. Today we'll be discussing the four major pillars of heart failure on a case-based approach. So this is the case is a 72-year-old woman with worsening dyspnea and leg swelling who is on furosemide. As told earlier, patient with evidence of fluid overload usually is being treated with the diuretics first. Her ejection fraction is 38%, so you can say that this patient has got a heart failure with reduced ejection fraction. That is less than 40% is called reduced ejection fraction. Her potassium is 4.2 and serum creatinine is 1.2. EGFR less than 35 ml is a contraindication for starting ACE, ARB or the RAS blockers. And hyperkalemia, potassium more than 5.5 is also a contraindication. So in the further management of the patient, these are the two things you should look for. One, what is the serum potassium, what is the creatinine, and then calculate the EGFR. So we'll be looking at how will you adjust the treatment in this patient. So this is the guideline directed medical management GDMD. The sequential therapy has been changed over to tailored approach depending upon the patient's problems and characteristics. The four pillars are the ACE inhibitors, beta blockers, mineralocorticoid receptor antagonist, and SGLT2. These are the four major pillars of management of heart failure. The how to start treatment etc. will be discussed at the end. So these are the four pillars. When the patient has got congestion, you go with the diuretics. So you can say this is the foundation for symptomatic relief. Diuretics are required. These are the RAS blockers. Then comes the beta blockers, the mineralocorticoid receptor antagonist, and then finally the SGLT2 inhibitors, irrespective of the presence of diabetes. And this is how you treat the heart failure with reduced ejection fraction. So remember the four pillars. So coming to AC inhibitors, ARBs and ARNI, that is angiotensin receptor neprilysin inhibitor. Example is sacubitril valsartan. AC inhibitors block ACI, and so it prevents conversion of angiotensin 1 to angiotensin 2, which is the very powerful vasoconstrictor, and so it produces vasodilation and reduces the afterload and preload, both are reduced. The ARNI, the sacubitril valsartan, where the sacubitril is the neprilysin inhibitor. Neprilysin is the enzyme that destroys the atrial natriuretic peptides, or the natriuretic peptides are destroyed by the neprilysin. So blockage of neprilysin leads on to enhanced natriuretic peptides, and so it reduces the afterload. AC inhibitors, ARB or ARNI, are first line therapy for heart failure with reduced ejection fraction. So first pillar, and is also indicated for heart failure due to myocardial infarction. So The reason is it will prevent the ventricular remodeling. If the patient can't tolerate ARNI either due to financial reasons or due to angioedema, you may go for ACE inhibitors. So, as mentioned, it prevents the angiotensin II formation, it reduces the preload, afterload, and ventricular remodeling in case of myocardial infarction. These are first-line treatment for heart failure with reduced ejection fraction, as I already told you. It is indicated in acute myocardial infarction, patient with hypertension with left ventricular dysfunction. Again, we can use this. What are the contraindications? Severe renal impairment, eGFR less than 30 ml per minute. You preferably don't use it. Hyperkalemia, serum potassium more than 5.5. Again, it's a contraindication. History of angioedema, ARNI should not be given. And a bilateral renal artery stenosis, again, you should not give. Sacubitril valsartan is preferred over ACE inhibitors and ARB in NYHA 2 and 3. The contraindications I have already mentioned, eGFR less than 30, hyperkalemia and angioedema. Always remember this. Do not combine ACE inhibitors with sacubitril valsartan or ARNI only after, they should use only after a washout period of 36 hours. So the patient is on ACE inhibitor, wait for 36 hours before starting sacubitril valsartan combination. The standard dose of ACE inhibitor or ARNI is ramipril. If it is ramipril, 2.5 to 10 mg per day, and enalapril 5 to 20 mg per day. But many patients are unable to tolerate up to this 20 mg. Sacubitril valsartan 50 mg, that is 24-26 mg BD, titrate to 200 mg, that is 97-103 sacubitril valsartan combination twice daily. So this is the standard dose. So again, remember, a patient, these ACE inhibitors preferentially dilate the efferent arteriole. So this is the glomerular Bowman's capsule. It preferentially dilates the efferent arteriole. So what will happen? The filtration pressure decreases. That is, the blood will easily pass through this. So the eGFR will decrease and the patient can have rise in serum creatinine. So when you start ACE inhibitor ARB, you have to check the serum creatinine after 1 week. And up to 30% rise, 25 to 30% rise is tolerable. More than that, you should discontinue. So the serum creatinine increases from 1 to 1.3. More than that, you should discontinue ACE inhibitor. So you should be checking the serum potassium and creatinine when you start the ACE blockers. Now go to the next case. A 60-year-old man with heart failure with reduced ejection fraction started on ramipril. 2 weeks later, he develops dry cough. So again, very important, common and a very common cause for a non-compliance is dry hawky cough without much sputum. This is due to ACE inhibitor induced bradykinin accumulation. So in such cases, you may switch over to ARB like losartan or valsartan. So major side effects are, and a significant proportion of patients can't tolerate ACE inhibitor due to the dry cough. Another important complication is angioedema. Somebody with angioedema should never give ARNI, that is valsartan sacubitril combination should not be given. Now the second pillar is beta blocker. Mechanism of action is beta blockers. It will block the B1 adrenergic receptors, decrease the heart rate, myocardial oxygen demand. Long-term use leads to reverse remodeling. And the indications are heart failure with reduced ejection fraction and stable euvolemic status. Somebody with increased fluid overload, usually we don't start beta blocker. In post-myocardial infarction, you can start somebody with arrhythmias and heart failure. Again, you can start contraindication, decompensated heart failure. So start only after initial stabilization. Somebody with a stage 4 NYHA or class 4 NYHA, you should not start. Severe bradycardia, heart rate less than 50 again. Some people, persons with hypertension, BP less than 90, again don't start. And heart block is also a contraindication for starting beta blockers. Standard dose, you can start on bisoprolol 1.25 mg up to 10 mg per day. Metoprolol, it is a succinate 12.5 to 200. So the dosage is usually smaller dose. You gradually step it up. Start with the small dose 12.5 mg. Carvedilol 3.125. You have to gradually titrate the dose. So this is the standard dose of carvedilol. Metoprolol, it is a succinate, not tartrate. Now we go to the next case. A 55-year-old man with heart failure with reduced ejection fraction and their 35% ejection fraction. She started on metoprolol. After a week, complaints of worsening fatigue and dizziness. What is the likely cause? Beta blockers are well known to produce fatigue, and the dizziness may be due to hypotension. So you have to reduce the dosage and temporarily and up titrate the dose gradually. Now the next pillar is MRA, that is mineralocorticoid receptor antagonist. The typical example is a spironolactone and eplerenone. Initially, we have discussed that angiotensin 2 will stimulate production of aldosterone. So it blocks the aldosterone receptors or the mineralocorticoid receptors. The main side effects are potassium retention. Prevents myocardial fibrosis and remodeling. So this is an important point. Indications are NYHA class 2 to 4 and heart ejection fraction less than 35%. Contraindications: hyperkalemia, potassium more than 5.5 and severe renal impairment, EGFR less than 30 ml per minute. So now the next case, a 65-year-old woman wants spironolactone for heart failure, has serum potassium 5.8. What is the next step? So serum potassium more than 5.5, it is stop or reduce spironolactone and monitor the potassium levels. So remember, on patients on spironolactone, especially when they are on ACE or RAS blockers, can develop hyperkalemia. Please remember that the standard dose of spironolactone is very much lesser than that we use for heart failure. So it is lower than what we use for cirrhosis. It is 12.5 to 50 milligrams per day. Eplerenone is 25 to 50 milligram. So that is about the standard dose. The fourth pillar is the sodium glucose cotransporter 2 SGLT2 inhibitors. Irrespective of the presence of diabetes, the drugs are dapagliflozin and empagliflozin. Mechanism: it inhibits SGLT2 receptors in the renal tubules, osmotic diuresis, reduce preload and afterload. DAPA and EMPA, there is only a single one dose only, 10 milligram. There is no up titration required. The side effects are genital mycotic infections, volume depletion, hypotension, and euglycemic ketoacidosis. Something to remember, patient can come with acidosis with a normal sugar. Contraindications are when the EGFR is less than 20, you should not start. History of DKA, and in type 2 diabetes, again Again, remember this is given irrespective of the heart failure. The other few drugs are, one is cardiac glycosides, digoxin. Digoxin has gone out of the main focus of treatment of heart failure. It inhibits sodium potassium ATPase, increases intracellular calcium, and increases positive inotropic action. It slows the AV conduction, so useful in patients with atrial fibrillation and heart failure. So the indications are heart failure. The heart failure with reduced ejection fraction is persistent symptoms despite optimal therapy. For patient with AF with a rapid ventricular response to control the heart rate. That is a control of the rate. The contraindications are advanced AV block, bradycardia, digoxin toxicity, that is nausea, visual disturbance, and arrhythmias. Paroxysmal tachycardia. Paroxysmal tachycardia with block is the characteristic arrhythmia that you get with the digoxin. The standard dose is usually half a tablet, 0.125 to 0.25 milligram or 0.25 milligram on alternate days. So the dosage of digoxin is lesser than what which has been given previously. So we go to the sixth case. 75-year-old man with heart failure is on digoxin. He presents with nausea, blurred vision, and confusion. ECG shows bradycardia, but it's likely because it's digoxin toxicity. So digoxin toxicity can present with arrhythmias, bradycardia, confusion, and visual disturbances, sometimes xanthopsia. Stop digoxin, correct hypokalemia, give digoxin specific antibody if severe. There is a management. So this table shows the summary of the drug class, and the next session we will discuss how to start treatment. Is it a sequential treatment or a stepwise treatment or tailored treatment? Stay tuned. Thank you.